Okay, we're going to get started again. We have a live aneurysm reconstruction with flow diversion. Our moderator for this will be Dr. Hopkins, and Dr. Elad Levy at University of Buffalo will be doing the procedure remotely.
Thanks. So this is an opportunity to talk about some really nice new technology. And in the group standing at the table, let me introduce everybody. At the head of the table, Elad Levy. Next
Hello.
to Elad, Adnan Siddiqui.
Hi,
Who's
everybody.
next? Travis?
Yeah, good morning.
Travis Dumont and Grant Sorkin. So our team in Buffalo is going to do this case. It's a new procedure, and before they do, let me just give you a little background on what we're about to do. Paul, can I have the slides? So this is the new Gates Vascular Center in Buffalo. Next. I want to mention two conflicts. One is that we are putting a device in from Covidien. We do get some research support from Covidien, and a couple of us get some honoraria for lectures. The other is Toshiba. It's the same deal with Toshiba. We get research support, and Toshiba has provided the research equipment, including angio suites, MRI, CT, and so on for the Gates Vascular Institute. So those are the two conflicts that are relevant to this participation, but I promise you there's no bias here. Next. So the flow diversion concept, if you think about this, it does redefine the treatment from an intrasaccular, where we fill the aneurysm with coils, to an apparent artery endoluminal reconstruction. In other words, rebuild the artery from the inside. So it provides a treatment option for some really complex aneurysms with very wide necks where we just don't have the right technology currently, and potentially for fusiform aneurysms. All that has been an unmixed blessing, and I'll tell you about that. So the downsides to putting in this device is that it's a woven mesh stent, and there have been some delayed hemorrhages, and they can be either remote from the site or aneurysmal, although more commonly remote, or, as you might imagine, when you're putting a new device into the artery like this, ischemic complications are also a potential problem. Next. So if you look at the study that Covidien did to get this device approved by the FDA, I think it was a great example of a well-designed study designed to get the product fairly evaluated and onto the market so that then clinicians could decide how best to use it. The complication rates in the PUFS trial were very, very low. That resulted in FDA approval, but important to note that the aneurysms we studied in that trial were below the ophthalmic, so these were mostly cavernous aneurysms. So just to bear that in mind. Next. So the device is kind of like a rolled up screen from a screen door, but it's very, very flexible, very, very fine mesh. The struts are 0.1 microns, so they're very, or rather 1/1000th of an inch. So they're very, very thin braided mesh, and it's 25% platinum, 75% nickel cobalt, and it's a little bit, it's somewhat visible. Not high visibility. The metallic coverage with this device, when you deploy it into the artery, is about 30 to 35% as compared to the traditional stents that we've been using, Wingspan and so on, that give you about 6 or 7% coverage. So it's a much more dense coverage. And they come in multiple sizes, and the pore size is 0.02 to 0.5 millimeters squared. Next. We have done our own trial, and just to mention that our results in the anterior circulation paralleled those in the PUFS trial. They were outstanding. In the posterior circulation for giant fusiform aneurysms, we've had some major problems, and I think some of that may be due to the fact that we've put sometimes 4 or 5 devices in, but we've got work to do to figure out how to solve that devastating problem of a fusiform giant basilar aneurysm. Next. Our experience is that for most cases, one pipeline device is enough. Where we've gotten in trouble in the posterior circulation, it's been with multiple devices. Now, there are cases where we might put a second device, particularly in the carotid, where we know it's safe, and we may do that today. But usually, one is enough. Even though it may not look perfect immediately, it usually will look much better a month down the road. Next. So here are a couple of case examples, just a cavernous aneurysm that 3 months down the road looks virtually normal. Next. You can see the outline of the stent. Another dissecting aneurysm that 3 months down the road looks beautiful. Next. Here's a middle cerebral, again, with a pipeline and some coils. Looks perfect. Next. A fusiform basilar. This is a smaller one that did well. And again, look at the remodeling. Next. And a giant basilar that was a beautiful angiographic result. This patient also did well. Next. So the concept is a customized stent delivery. In other words, it's a little bit tricky to deploy, but as you deploy it, you can actually, when you can deliver a little bit and then push it back and bunch it up so you can actually get a higher density across the neck of the aneurysm if you're careful. Next is an animation that just shows you conceptually how this thing works. You pull the sheath back, the stent deploys, now you bunch it up, and that creates a little higher density across the neck. Next. And then these are some computational fluid dynamics studies showing in the bottom right how beautiful the flow reduction can be when you analyze what happens after putting in a pipeline device. So with that, I hope that explains the concept, and let's go live. And Lad, you want to take it away?
Sure. So this first case is a 68-year-old woman presenting with right eye blurred vision. She went to an ophthalmologist and eventually ended up and was found to have a greater than 1 centimeter cavernous aneurysm. This aneurysm was causing optic nerve atrophy with her field cut and was also causing compression of some of the nerves running through the cavernous sinus. We typically don't treat cavernous aneurysms, but clearly this one was symptomatic and this woman was deteriorating. Next slide. This is just an example of her ophthalmologic exam showing the field cut. Next slide. And this is part of her workup showing an aneurysm measuring a little over 1 centimeter fusiform, beginning in the cavernous portion of the carotid artery, but also then penetrating near the ophthalmic segment and the dural ring. Based on the fact that she was becoming blind in that eye, developing cavernous sinus nerve compression, and because we thought it extended into the intracranial compartment, we elected to treat this with flow diversion in order to reduce the mass effect. Next slide. So this is a typical 3D workup that we did prior to today, or her diagnostic angiogram showing this aneurysm and the lateral projections. Next slide. And here is the working view we're going to work with today. So I think now we're going to start with our first run. If we can fluoro, Adnan, if we can go to the patient. This patient is awake. Can you come off roadmap, please? So she's awake and she's very cooperative. What we have so far is a very thick guide catheter and then a smaller catheter within that one, sort of a tower of power technique to get us parked with rigidity in the petrous carotid. This will allow us to push what we call heavy metal into the intracranial compartment without having our support herniate into the arch. Run, please. Excellent.
You want to explain why you see a little bit of movement, Elad, with an awake patient?
Yep, she's awake. She's very cooperative. She's a little bit of a heavy breather. Can you clean that up, Gene? And let's fake that. We're going to start going up with our micro apparatus. So we have a Marksman catheter, which is a catheter designed to put this flow diverter through, and the gold tip Aladdin wire.
So you've got a triaxial
Fluoro,
system?
please. So we have a triaxial system. We have a Marksman and a reflex, which is very flexible, in a standard Cook shuttle, which is a very heavy catheter, guiding catheter, which we usually use for carotid stenting.
Paul, let's give a lateral fluoro. Are you ready with the roadmap, Gene?
So you're going to start seeing a catheter and a wire come up. I'll roadmap her when I get there.
So now we're seeing two catheters. Looks like the Cook shuttle on the lower marker. And then
yep, and now you can see a lead wire coming right now into the petrous carotid. Now we're going to do a roadmap. Roadmap, please.
Yep.
Hold nice and still. Hold nice and still.
Nice and still now, hon.
Okay.
So working with an awake patient does mean we have to do a little more in the way of road mapping. On the other hand, we've got an awake patient, so we can tell exactly how they're doing, and if there's any issue, we're going to find out about it very quickly. Plus, the impact on the patient is
So
significantly
now we're
less.
crossing the neck of the aneurysm. You can see we have the wire. And if you look on the lateral, we're going to try to avoid this very large PCOM vessel. She sort of has a PCOM. You can see the wire trying to navigate past that PCOM. We're a little bit stuck there, so we're going to back it down. We definitely don't want to perforate anything. Try to rotate off it. There we go. And now we're in the bifurcation in the A1, but we're actually going to try to select the MCA if we can, and we just selected the M1 on the AP projection, and now we're going to go into the distal MCA candelabra because we need distal purchase to bring up what is a relatively heavy catheter, that Marksman catheter. And it needs to be heavy because it's going to deliver a heavy mesh stent. So here comes that catheter again on the AP. We're at the ICA bifurcation. I need a little bit more on the reflex.
That as we go.
I'd like to get into the M1. Bring the shuttle if you can. Okay, watch out. You're losing the reflex.
You look at the AP view that's on your left, you can see the tip of that catheter now entering the M1.
Yeah. And now we're in the M1. We'd like to get past that bifurcation so the wire doesn't inadvertently go into the superior trunk. And I think we're in a good place to bring up the stent. So the first stent we're going to use, we measured her internal carotid at about 4.2 millimeters distal to the aneurysm and about 4.5 millimeters proximal to the aneurysm. So we're going to size this at about 4.2, 4.25 millimeter stent.
Let's see what. There we go. You want to push it forward?
So we're going to get a new road map because she did move.
Let's get it up there. We'll do it.
Okay.
Hold it up there.
So Nick, do you want to talk about the sizing of these stents?
Sure. The deal here is to try to oversize it a little bit. This is when you put this stent in your hand, the filaments are so fine that you can barely feel it. And so you want to oversize it so that it hugs the wall of the artery and will grow into the wall of the artery, giving you better endoluminal reconstruction.
You can see the stent coming up now, Nick. You can see there's a lead wire. That's the first tip marker. So there's about a 2 centimeter lead wire, which is not the stent. Then there's a nose cone, which basically caps and keeps the stent constrained in the catheter.
I think, Paul, you need to enlarge the fluoro image so we can see it better.
Let's go on the high zoom, please. Max mag, 1.4 fluoro zoom on the AP, please. I won't work through that. Okay.
You want a road map now, or you do a road map?
Road map, please.
Bonnie, nice and still now.
We're ready with zoom.
Go ahead.
Okay.
Hold nice and still now. Okay.
Go ahead.
So we'll wait for that road map to take. And now we can see the lead wire is coming distal to the aneurysm. The nose cone is crossing the neck on the AP and on the lateral.
Paul put in the native film as well up there, AP and lateral?
It is.
No, up there.
So it's okay. And now we want to be distal. We want to be distal to the aneurysm because this has a tendency to prolapse. It's much easier to pull the whole system back than it is to push it forward. So you can see the nose cone is entering M1. That's not where we want to end up by any means. So now we're distal and proximal. Ideally, we see the PCOM on the lateral. We want the stent to be just proximal to that. So now we're going to start unsheathing on the AP. You got the reflex, Dr. Siddiqui, Adnan? Okay, the reflex is coming up a little bit, so maybe just pull on the reflex a hair. So the triaxial system, there's a lot going on. Pull the reflex back, please. Can you load a torquer onto this wire, please? And to deploy this, we have to basically unscrew that distal cap once it gets out of the stent. So so I'm going to start pushing forward. No.
You're doing it. You're all complete control.
Don't. So now the cap is out, and I'm going to start unscrewing. We're just at the level of the PCOM.
You can pull it back a little bit.
I'm good. And it's hard to see, but if you look at the native views, it's starting to open up distally. No, I'm not going to pull it back.
The other thing to remember.
So now the stent is coming out. Can you go on the native view, Paul?
Yeah, he is.
So the stent is open distal. I'm just pushing.
So delivery is
You
kind
can
of a
see how nicely it's
push-pull.
opening it. Yeah.
We don't want this to windsock or herniate into the aneurysm.
Very nice. You can see how it just opened around that paraclinoidal
Show the
aneurysm
native,
neck.
the non-subtracted view on the lateral, please.
I think
Even
Paul,
the
can you
AP could
show
be
us
very
just
nice.
the native views with all the rest? Just the native views.
Oh, nice.
Come off roadmap.
If you can enlarge those, we can see the stent better.
Step off roadmap.
There it is.
Okay, lateral view. You can see how we're just expressing this, keeping pressure on the catheter so it doesn't buckle.
There's a little torque there. You have to release some tension.
Yep.
I got
So
that
now I'm going to
reflex.
pull on the catheter just a hair to relieve some tension but not herniate the stent. So it's as Nick said, it's a push-pull. So if you look on the lateral, there's a little there's a little twist in the stent.
Just go ahead and push it.
And there it opened up.
Okay. Go ahead, push it in more. So there you go. Let's get access through it. There you go.
So
You got it.
important to remember this
So
is
now it's open.
It's a woven mesh stent,
So-
so that it will foreshorten when you deploy it. So you've got to take
Now
that
we're going to
into
do
account.
now we're going to do a run. If you can look on the AP view, Paul.
Bonnie, nice and still now. Hold your breath. Hold your breath.
Run, please.
Do not breathe. Do not move. 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 You can breathe.
Look carefully. you
Fluoro
can-
now. I want to show the stasis. Hit fluoro. So if you look on that lateral view, go to the lateral view, Paul. You can see a meniscus of contrast there. This was not there earlier. So already we have stasis in the aneurysm and slow flow, despite heparin, aspirin, and Plavix. Okay, let's go to let's go to a biplane view, Paul.
So it looks like the
Right now,
neck is beautifully covered.
I think, Nick, the aneurysm is well covered. We have good purchase exactly in the landing zones where we thought we would have. And now Alad is going to go up and try to retrieve the capture coil.
It's okay. I don't think we're going to put another one in because we already have stasis in the aneurysm.
Let's go do another
So
round.
we're going to do another run, but to your point, one is enough. You don't want to thrombose this thing immediately. We already have a change in flow that is readily apparent on anticoagulation. Run, please. Hold your breath. Hold your breath.
I'm going to go next door. Okay, I'm gonna
Yeah, it's filling slowly, and there's a lot of stasis already. So it looks like you've deployed it in a way that really got good density over the neck of the aneurysm. So
Yeah, you see a lot less filling in the aneurysm. Can you run that back for us, Gene? You see a delayed flow now into the aneurysm. You can see the vessels all wash out, but the aneurysm is still filled with contrast. Can you show the lateral there on the monitor, Paul? The lateral view. Okay.
So the nice thing about this technology is when you saw it, we started pretty much from scratch. Probably took, 10, 15 minutes to get the delivery catheter up there.
You can see the dye hanging out still in the aneurysm. So, Nick, we can place another one if you like. I can see clearly that there's stasis and thrombosis there already happening. would you put another one in, or anybody on your panel there suggest another one, or enemy of good?
I think the enemy of good is perfect, and I think the likelihood is you come back in a month, the aneurysm is going to be gone. The beautiful thing is if you come back in a month and it's not gone, it's easy enough to put another stent in.
Yeah, I think we've taken the pressure head out. I'm going to do one more run. Can you show, and you can just see that there's so much less pressure in the aneurysm, and once the heparin wears off, this thing will most likely be occluded. Run, please. Hold your breath, honey. Hold your breath.
On that left-hand view, you can see the outline of the stent and the stasis that exists.
I mean, there's still stasis there now. So the outflow of this aneurysm has been severely impeded. There's already thrombosis occurring in this part of the aneurysm. There's significant change in flow. So I think for today, this aneurysm is done. And maybe in the last 18 minutes, we can go into the second room.
So bottom line is, this is a procedure that, is it perfect yet? No, but I think it's a nice advance. This was an aneurysm that had about a 6-millimeter neck, and it was just about 14 millimeters in the largest diameter. And one stent and about a 30-minute procedure total has probably cured this patient. And I think that if we do have to do more, we can do it. The likelihood is this is going to take care of it. And it'll thrombose slowly. There's very little risk of rupture because it's never ruptured before. So I think a great example of how the technological advance that's occurred in this area has made a big difference in the way we manage these patients. Imagine what we would have had to do for this patient surgically. It would have been a tour de force to get that aneurysm taken care of. This makes it a whole lot easier. So given the fact that that one went so smoothly, we do have another patient that is ready to go. And Adnan and Ken and Travis, do you want to tell us about this patient?
Yes. Yeah, show the slides, please. So this is a woman with subarachnoid hemorrhage, Hunt-Hess-Fisher 3, with improvement after a couple weeks in our ICU. Next. This is on her initial presentation. She had a coil embolization procedure. Next slides. Oh, sorry. The 3D shows irregular morphology and daughter sac within the aneurysm. This was a rupture. This was after the coiling procedure, which was a couple weeks past now. And we've had some experience with this in the past. What we worry about with this, although it looks very good now, it's dome protected, over time, the force of blood into the aneurysm itself can cause compaction of the coils and a recurrence. Show the next slide. This is just a similar case to illustrate that point, which was reconstructed with a stent and coiling technique, and you can see it, in this case, a very dramatic compaction of the coils, resulting in a recurrence that needed treatment. For a patient with a history of rupture now, we want to avoid this, and so the plan, and what we feel is truly best, is flow diversion. Go to the next slide. So here's just our plan here. You'll see the coils which are already in place, and the pipeline will go overlying. Go next. Straightforward access already, which we have in place.
So at this point, we'll go live to the patient. And as Travis said, there's a good dome protection of this aneurysm, but the base of the aneurysm is very wide and is incompletely treated. And we can't leave that base unprotected because this is a ruptured aneurysm and will recanalize.
Okay, so let's get a roadmap off of that, please.
100% contrast, please.
Tell us your rationale for why you coiled it initially, guys.
Well, so based on ISAT and even based on the BRAT trial from Barrow, it's clear that patients who have acute rupture seem to do much better with endovascular techniques if that's possible. We are avoiding acute retraction. We're avoiding major problems with acute surgery, temporizing the measure.
Adnan's going up with a wire trying to cross this broad aneurysm at this point. I think the question also is why did we not flow divert right away? Flow diversion requires aspirin and Plavix. The acute rupture state, we have to put a ventriculostomy and there's significant ICU management. Having Plavix on board definitely complicates the issue, and we do what we can to avoid stenting in a subarachnoid setting. We're several weeks post. Most of her stuff is out or at least is in right now. We want to definitively treat this before she's discharged because it is a rupture.
Right, that was the point I was getting at. You had a ruptured aneurysm with a big bleb on it that was high risk for re-rupture early on. And placing enough coils to fill the aneurysm without worrying about getting tight compaction and not having to worry about placing a stent, which requires aspirin and Plavix at the time, is a nice way to temporize. And then you can let the patient stabilize, and obviously a very sick patient, and let the patient stabilize and then come back in a more leisurely fashion.
1.4.
And that's what we're doing here.
You're doing a roadmap from here.
Let's mag up all the way and fluorozoom 1.4, please.
Give me a torque.
It's coming.
New roadmap, please.
I got it.
Okay. Hold nice and still, honey. Nice and still. So you can see the motion artifact from her breathing. Hold nice and still. Using a gold tip?
Yep.
Okay, so we're going to try the same combination as last time. Can I get a headliner wire, please?
Exactly. Headliner double angle, please.
You're clean. Take it. Yep, I'm just shutting this off. So he's across the aneurysm now. He's anchored in the PCOM, so we're going to pull that wire back on the lateral. And he's going to try to twist out of the PCOM. Just go up with, pull the wire a hair back. There you go. Go. Okay, MCA. You're fine. Keep going.
One question that has
So if you look on the AP, he's now going across the MCA bifurcation. What's that, Nick?
Well, one question is, with these aneurysms, you are going to cover the ophthalmic artery, and you might sometimes cover the anterior carotid artery. To our knowledge, there's never been an anterior carotid artery stroke with one pipeline. On the other hand, if you are crossing the anterior carotid, you would probably want to really think carefully before you put another one across, because that would be a devastating complication.
Can you show the native and non-native images, please? Okay.
Go ahead, Noel, please. So the tricky part here was to really cross the lesion. Now that we have our microcatheter, just as Alad showed in the last case, our goal here would be to land the proximal end of the stent just at the level of the PCOM, therefore hopefully not having to cover anything of importance. And as Dr. Hopkins mentioned, almost always we have excellent collateral from the external circulation, so that ophthalmic. Let's start off with roadmap so I know I can get it without getting into ventricular striate. So you'll see my device coming up in a second.
So what size device are you using, Adnan?
So this is a 4 by 18 as our first device. Again, 4 is a bit large for supraclinoid, but because we're planning to use hopefully just one device, we have to size it.
There's your reflex.
Yeah.
Relax a second, please.
Uh-huh.
So I'm going to push his. This is a triaxial system. Again, when you're pushing heavy metal, heavy stents, you can't do that with the normal neuro guides. So we have a typical carotid type stent guide with another guide in that called the reflex, and then the marksman catheter. He's got the catheter in the MCA. He's got the wire in the MCA bifurcation. The nose cone now is a 2-centimeter wire. Then the nose cone is coming out into the M1, and he's probably going to watch his wire so it doesn't go any further distal.
Can I have the torque device, please?
And now he's going to unscrew the retaining cap off the stent to release it. That's constraining the stent so it can go through this microcatheter.
So you're slowly pulling back.
You're very
Again,
distal.
I know. my main view that I'm really using here is my lateral. You can see my reflex climbing up, which is okay. I'm okay with that.
And as he's doing that, he's pulling the whole system back, because as we said, it's easier to retrieve and pull back than it is to push forward. I just put pressure now.
Yeah, and you can see that there's been a detachment already from the capture device, which is a big concern when we first start off.
Just push, don't unsheath.
Okay.
So,
Now, can we...
So if you look on the lateral native, you can see the stent is distal to to the coil mass. There's still a lot of stent to come out of the catheter. Just push.
I'm giving some positive pressure. Watch your reflex.
As he's pushing this heavy metal, it wants to herniate our reflex.
That's okay. I'm doing it.
Where's your
Okay?
stent?
You're done.
Now it's deployed.
Okay. So now it's deployed, and we're going to do a run. He's coming back through the stent to ensure that it's patent, if it's easy. And he's wired back into the MCA in case there's another one he wants to put in, which will be very unlikely, given that there's a coil mass already.
I have it ready.
Hold your breath. Hold your breath. Can I have a run, please? Hold your breath. Great. Can you clean that up, Jane, and freeze it in the mid-arterial phase, and we can take a good look? Oh, that's beautiful. So I think Adnan has a stent very well opposed across the carotid, across the ophthalmic aneurysm. He actually was able to land the stent, if you look closely on the lateral, just proximal to choroidal, which is ideal, at the level of the PCOM, just at the level of the PCOM, which we're not worried about. So this is a very well placed stent.
So what do you think, Nick? You want another one? Nick?
You need another case, Adnan?
Do you, no,
Not another case.
no, not another case.
I think our hearts aren't going to take another case.
I don't think I want another
Would you
stent.
like another stent?
I don't think I want
Yeah,
another
that's
stent.
what I was wondering. Okay.
All right, so we're going to take out the microcatheter and do a final run, just so we make sure we don't malpose the stent on the exit of the catheter. I'm going to do it through here.
Again, you've given this patient a nice barrier to flow into that aneurysm. Betting
please.
that plus the coils is going to
Hold your
result in
breath.
complete
Hold your
thrombosis.
breath. Hold your breath. Don't move. Don't move.
Patty, don't move. Don't move.
Oh, perfect.
Looks really good, guys.
Guys-
And I don't see any filling of the aneurysm at all in early phases. So that means it's really, you've altered the hemodynamics significantly already. So I don't see any real need to put another one. Do you, Adnan?
No, I actually don't see much filling of the aneurysm. What you do see is shine through of the carotid flow. What you see is shine through of the carotid flowing in back of the aneurysm on the lateral plane.
The MCA.
On the A plane, on the AP plane, you see the M1, but you really have a minimal filling of this aneurysm. Again, she's on heparin, aspirin, and Plavix with the coil mass and the stent. I think she's going to have, and she has, a fantastic result.
Why don't you talk a little bit about the treatment options for these types of aneurysms before this? Things you would have thought about if you didn't have pipeline, both on the surgical and the endovascular side.
And I'll just make a comment and I think what's important to remember is whenever you're treating aneurysms, it's not anymore about coil versus clipping. It's really about what are the tools out there, what are the skill sets of the institution, what can be done in the safest possible way for your patient in your hospital. There are many tools out there, and the better we can understand the tool sets and the skill sets, the better we can tailor procedures for specific patients. So it's very reasonable to clip this patient, but she came in as a Hun-Hess 4, so we elected to coil her. We don't really want to take a Hun-Hess 4 or 5 to the OR. We coiled her, we patch coiled her, and she did very well, and over the course of about a week, she woke up and made a very reasonable recovery. So now that merits a definitive treatment. We elected to do flow diversion at this point. Had she have been healthy grade, Hun-Hess 1, Hun-Hess 2, very reasonable to consider clip ligation for this aneurysm. Adnan, what are your thoughts?
So I think from our standpoint, when we look at our own data that we have published on paraclinoid aneurysms, we are able to endovascularly treat these with extremely low morbidity and mortality without need for secondary cervical exposure, without need for optic nerve decompression. And with flow diversion, one other concern that we have had in terms of packing coil mass opposed to the optic nerve, as you saw in Alad's first case, is really avoided. And so you're reconstructing the vessel pretty much the same way as you would microsurgically, only you're endoluminally reconstructing the vessel rather than exoluminally with a clip. So I think flow diversion really for the proximal carotids, and that's a point that needs to be reiterated, really the data supports excellent use within the proximal carotid. That's the on-label use. That's the kinds of cases you can do with this, including the ones that we showed today. But when we have ventured beyond the confines of the on-label, really the morbidity and mortality of the procedure becomes much more unclear. Certainly, we have published on our experience on vertebrobasilar giant aneurysms, particularly the fusiform variety, and there seems to be no real good solution there, at least as in present. So I think this is a great step forward because finally we're starting to mesh biology of the disease with the treatment options, true mark of translational research. And
just a comment on the first case you saw with the cavernous symptomatic, the key was she was a symptomatic unruptured aneurysm. For patients who fail balloon test occlusion, vessel sacrifice is not an option. That would be an excellent option for patients who do fail balloon test occlusion. Other options for that aneurysm include a bypass procedure. But again, you saw we're able to do this awake in about 30 minutes. So from a patient morbidity standpoint and from a skill set of an institution standpoint, obviating the need for a high flow bypass or another type of bypass for this type of cavernous aneurysm is a huge iterative jump in technology and a huge step forward for aneurysm treatment. Are these fraught with complications? Absolutely. Nick showed a slide in the beginning showing about a 6% complication rate. In the posterior circulation, when we ventured in, beyond the VB junction, complication rates have been prohibitive. But for the right patient with the right anatomy, I think it's a very safe procedure, and I feel that it's really a game changer. Nick, any final comments?
Well, I think that you mentioned the posterior circulation morbidity, but most of the morbidity we've had in the posterior circulation has been in patients where we had a real big fusiform aneurysm and where we used multiple stents. And in that situation, we've had complications. It'll be interesting to see as we go forward whether we can reduce the rate of significant morbidity by placing only one stent across a large vertebral basilar fusiform aneurysm. And that's one of the things the company's done for us recently is they're now starting to make much, much longer stents. And that will, I think, be a big boon because when you start having to overlap these things, technically it gets more challenging. It is a little bit tricky to deliver them, as you saw, but that push-pull technique of pulling back and letting the stent come out and then nudging forward to expand it, not only expands it, but it also creates an area of increased density of the stent mesh at the neck of the aneurysm, and that's what we're looking for. I think exciting to look back at our own center. If we go back, oh gosh, over 20 years, when A.J. Wakalu and Baruch Lieber started stenting aneurysms, that led to the collaboration with our aerospace engineering group and the genesis of the Toshiba Stroke Research Center, where lots of interesting things have happened over the past 20, 25 years. It's just been a wonderful opportunity for us to combine translational research with the clinical procedure, which is really what this is all about, isn't it? We're seeing an idea turn into a product that gets approved by the FDA. This one just got approved. Basically, we're now still in trials. We need to keep studying these patients. We need to keep recording the data so we learn more and more. But all in, it seems like we've, at least for some aneurysms, we've really got a whole new world here. And I just want to thank all the team in Buffalo, amazing group of guys. All
I'd like to thank the CNS for the opportunity and thank them for giving us the opportunity to showcase two aneurysms at this meeting. So thank you, and thank you,
very
Nick.
much.
Absolutely. It's a great opportunity for us to be able to share with you the work we're doing, and so our sincere thanks to the Congress of Neurological Surgeons. Thank you, guys.